I want to ask you something. Think about your most successful implant case, the one you are most proud of. Now ask yourself 5 years from now, will that bone level hold? Osseointegration is solved science, and we have mastered the fixture in the bone. But every year we lose implants, not from below, not from osseointegration failure, but from above, from the collar, from the zone we have been quietly ignoring. If osseointegration is not the problem, what is? And why have not we fixed that yet? Here is something no one told us in dental school. When we place an implant, we create a wound the body can never truly heal, not in the way it heals around a natural tooth. Around a natural tooth, perpendicular collagen fibers lock into cementum. They create a true mechanical seal. Around the titanium implant, the body's best response is formation of parallel collagen fibers running alongside the surface, like a furnace leaning against a wall. It holds, but it is not attached. How many of you have placed a smooth collar implant because it felt safer? That smoothness is actually the problem. The smoothness promotes non-gripping mechanical seal. If the seal is always compromised, what happens over time? And is there anything we can actually do about it? This slide has a name I use with my team. I call it the domino slide because once the first piece falls, the seal, everything else follows on a timeline. We can set a watch to walk through each stage slowly. The compromised seal results in microbial invasion that inflames the peri-implant soft tissue. Subsequently, the bone resorbs and the soft tissue recedes. This is not a story about patient non-compliance or bad technique. This is biology following its rules. When the bacteria get below the epithelial attachment, inflammation is the only response the body has, and the inflammation at the crest means bone loss every time. This predictable pattern of bone loss around a traditional implant is not a clinical failure but a biological compromise we have been forced to accept. We used to call this expected remodeling. We gave it a polite name because we had no alternative until now. That phrase until now is a door. What changed? What is the until now referring to? Is there actually a way to stop this cascade? What you are looking at is not just a dental implant. This is a communication device, one that speaks directly to your cells in the language they understand. The geometry. Every micron of this surface is a deliberate instruction. And here is the part most people find surprising. Your body does not heal randomly, it follows a script. The question is who wrote it? It is written by the precision geometry engineered at the scale of a single cell. The upper coronal zone of the implant collar is the danger zone where bacteria wage war and soft tissue tries to migrate apically. These 8 micron grooves are narrower than the most bacteria. They create a physical stop sign for the epithelial cells telling them this is not your territory. And in that same space, they invite connective tissue to grip, orient, and anchor. Think of it as a biological bouncer. Some cells get in, some don't. Now, in the lower apical implant collar, the microgrooves widen to 12 microns that are specifically designed and optimized for contacting osteoblasts to promote osteogenesis. That is not by accident. Bone cells need more room to orient their collagen fibers. These wider channels provide contact guidance. They don't just say attach here, they say attach here in this direction, building perpendicular to the surface. That is how you get true osseointegration. It is not just a surface adhesion. The bone does not just touch the implant, it reaches into it. Laser-Lok works by using the principle of contact guidance that directs cellular behavior at the microscopic level, a well-known phenomenon in cellular biology. When the fibroblasts encounter a surface with channels that match their dimensions, they don't wander randomly as on the smooth surface. They attach, align, and organize. How exactly does a groove on titanium surface tell us a cell what to do? What does the attachment actually look like? I want you to think about highway lanes for a moment. Without lanes, vehicles move in every direction in chaotic, inefficient, collision prone manner. Add lanes and suddenly thousands of vehicles move in organized and predictable flow. That is exactly what Laser-Lok does for the cellular behavior. These cells move randomly over the smooth surface implant collars and deposit collagen fibers in parallel fashion without any functional attachment. We spend decades trying to roughen the implant surface to get better bone attachment below. That roughness below the crest works beautifully, but the same roughness at the collar creates chaos in the soft tissue. The cells respond by attaching at random angles. We get more surface area but no organization. The Laser-Lok microchannels force the cells enter the grooves, align perpendicular to the surface, form a structured functional barrier. Same biology but completely different set of instructions. The geometry makes sense, but does the body actually respond the way we are predicting? Is there real biological evidence for that? How Laser-Lok guides fibroblasts to engineer a true perpendicular fiber attachment. At high magnification, the Laser-Lok microchannels are perfectly parallel, engineering a perpendicular fiber attachment for stable connective tissue seal. Fibroblasts approach the cell-sized microchannels, align and elongate along the channel direction, then secrete collagen fibers not randomly but with purpose. These oriented fibroblasts guide the collagen fibers organized perpendicularly, creating a dense, stable connective tissue seal at the transmucosal implant surface. This prevents scar tissue formation and promotes a structured, functional connective tissue barrier. Laser-Lok channels guide fibroblasts to restore nature's design. At high magnification, the histological analysis confirms what engineering predicted. Theory is important, but evidence is everything. Epithelial downgrowth, a hallmark of traditional implants, is effectively inhibited. The cells stop where the microchannels begin on the Laser-Lok implant collar. You can see the epithelial cell attempting to migrate apically, but Laser-Lok inhibits every attempt that is made. Below, a physical connective tissue forms that is dense, organized, and perpendicular, not like that of the traditional implants where parallel scar tissue forms. At high magnification, the histological analysis reveals epithelial downgrowth reaching bone, loose scar tissue forming leaky, compromised biological seal in case of traditional implants. The sheet of epithelial cells migrates apically along their smooth implant collar without facing any resistance. Parallel scar tissue forms below the epithelium in case of the conventional implants. The traditional implants show a long junctional epithelium and parallel scar tissue. While as the Laser-Lok is unique as it replicates the natural biological seal. Histological analysis confirms that Laser-Lok is unique in its ability to inhibit epithelial downgrowth and establish a physical connective tissue attachment, not just a claim but proven at cellular level. 0.59 millimeters. Histology proves the mechanism, but clinical proof demonstrates the outcome. Let me ask you something. What number comes to the mind when I say acceptable bone loss around a dental implant? You already know the number 1.5 to 2 millimeters in the first year, then 0.2 millimeters for every subsequent year. That is what we were taught, that is what the textbooks say, that is what we have accepted. But here is the question we stopped asking. Why is that acceptable? It is because when a machined collar fails to seal, the body resorbs bone every time predictably, and we call it that biological width instead of what it really is, a biological compromise we learn to live with. Now take a look at these two implants placed at the same point of time in the same patient population with same loading conditions. One on the left and one on the right. Left side, you have seen this 1,000 times. Bone loss exposed the threads. That familiar dark gap under the collar. And the right side is something different. The bone is right where it started, with no gaps and no threads exposed. A crest that looks like the day it was placed. At 37 months post loading, the conventional implant gave us what we expected, 1.5 to 2 millimeters of bone loss. But what about the Laser-Lok implant? Only 0.59 millimeters. That is not less bone loss, that is a different category of stability. So, here is what I want you to sit with for a moment. If 1.5 to 2 millimeter was acceptable only because we had no alternative, what happens when an alternative exists? Does acceptable suddenly becomes unacceptable? Because that is exactly what the data is asking us to reconsider. How Laser-Lok does this? Not by magic, but by geometry of contact guidance achieved through microchannels. A seal that actually seals. But first, just remember this number of 0.59 millimeters, because that is not just a number, that is 37 months of proof that we don't have to compromise anymore. The bone numbers are extraordinary, but is this technology actually proven over years of clinical use, or is this still emerging? Who else is saying this besides the company?